And we are just so excited to be here, so excited to have all you here. This is groundbreaking, first of its kind, this community coming together to just really get educated, get connected with one another. Totally exciting. We're so happy to have you. So this is the place where you get started on the journey. This is what to do when you want to get pregnant but can't, beginner's guide to infertility. And it's so exciting that we have today on our panel wonderful experts in this field to help guide you. And it's just thrilling. I have chills being a part of this. Personally, my own journey is I'm excited to learn about fertility, empower myself, and it's just great to have support to do that and education to do that. So this is just amazing. So basically, this is a safe space. We're going to have a Q&A at the end, so save your questions and feel free and safe to ask anything. There's no question that's too small or too big. We want to welcome you to feel safe and comfortable here to get the education you need and the access you need to help you on your journey towards parenthood, because really that is what it's about, isn't it? So very exciting. Okay, so we have a wonderful panel here. We have our moderator. This is Holly Gregg. Holly Gregg is a bloggist. She has a blog called Ready to Be a Mom, which focuses on the pain and difficulties in her journey towards motherhood, as well as issues facing the infertility community at large, and her own personal experiences of being a parent after infertility. So that's very exciting. And Holly is actually the recipient of the 2012 Hope Award from Resolve. And for those of you who don't know, Resolve is the National Infertility Association. So the Hope Award is for the blog of the year that was given to Holly this year. So congratulations to Holly. And then we have Dr. Mars, Dr. Richard Mars, and Dr. Mars is a leading reproductive endocrinologist. He's from California Fertility Center, and that he's board certified in both obstetrics, and it's a really hard word to pronounce, obstetrics, and gynecology, and as well as reproductive endocrinology and infertility. And then next to him we have Dr. Lee. Dr. Li Wang Li is a reproductive endocrinologist at Pacific Fertility Center, that's in San Francisco. And she treats all forms of reproductive disorders with a special interest in PCOS, fertility preservation, and egg donation. And then we have our Doctor of Chinese Medicine, Denise Wiesner. And Denise Wiesner is the founder of National Healing Acupuncture. She is a board certified acupuncturist, board certified by the state of California and the national governing body to practice acupuncture, herbology, and Chinese medicine. And so that is our panel, and I just want to welcome you all today to Fertility Planet, the first of its kind, a complete groundbreaking experience, a landmark show. And now I will turn it over to Holly, our moderator, Holly Gregg.
Thank you so much, Justine. Welcome, everyone. So we wanted to kind of start with you guys and tell you a little bit about what we're doing. We're talking about the beginner's guide to infertility, what to do when you're trying to get pregnant and you can't, before you do anything else, what comes first. What to expect when you're visiting a specialist, when to actually go see the specialist, what kind of treatments might be available, and as well as some natural techniques that might help with fertility. So I know people aren't always comfortable with this, but if you don't mind a show of hands, how many of you have already been through some sort of fertility testing or met with a specialist and a reproductive endocrinologist? Okay, and is there anyone in the room who's never seen a specialist, okay, great, that's always good to know, who's just sitting here wondering, when do I go, what do I do? Our panelists here are going to really help us answer a lot of those questions, and I'll let Dr. Mars start by telling you a little bit about who he is and what he does.
Good morning. This is an exciting event. I've been fortunately involved in some of the planning, and this group, the Fertility Planet, I think is going to be an amazing help to patients, consumers in this area. I've been involved in fertility medicine since I left my home state of Texas and came to California, did a fellowship at USC, and While I was there, we formed the first IVF center in the West Coast, the second in the United States, and never made it back to Texas after that. So I've been involved in mainly IVF technologies and development as well as clinical practice. We have a center in West LA, California Fertility Partners. We have a large group of people, MDs, PhDs, and pretty much do every aspect of infertility, from basic workups to genetic testing of embryos. It's an exciting 32 years, and every day it's exciting. You never know what's going to walk through the door.
Right. Dr. Lee?
Hi, everyone. Welcome. I am really honored and privileged to be here among this esteemed panelists. My name is Li Wing, and I am one of the reproductive endocrinologists at Pacific Fertility Center in San Francisco. We are one of the largest and most experienced fertility centers in Northern California. All of our physicians together have been seeing patients in infertility for over 20 years. I'm one of the most junior ones, so obviously I don't have a 20-year experience. We treat patients of all infertility etiologies. We also serve a very large international patient population from Asia and Australia. And up in Northern California, we also serve a very large LGBT community, providing services in egg donation, sperm donation, donor sperm insemination, gestational carrier services for our lesbian, gay, and transgender families. Recently, over the last several years, our practice have launched successful programs in fertility preservation, genetic testing of embryos, like Dr. Marr said, also with comprehensive chromosomal screening. And recently, we've also launched one of the only freestanding frozen egg bank in Northern California to complement our ovum donation program. A little bit about me. I started my medical career at Harvard Medical School, where I earned my MD degree, and then I did my obstetrics and gynecology residency at University of California in San Francisco. And during medical school and residency, it really became clear to me that my passion is in reproductive medicine. So I pursued a fellowship in reproductive endocrinology and infertility at Columbia University Medical Center in New York. But you know, once you've been to California, you can't leave. So my family and I decided to come back to San Francisco and be in private practice since then. One of my long ongoing goals and commitment is really to help my patients, women and men, build their dream family, one healthy baby at a time. And it's really a pleasure to work with a group of physicians who also share that commitment. On a personal level, as a woman and a young mother, I have experienced firsthand what it feels like to want to conceive and have a baby. You know, I've experienced the anticipation, the excitement, the anxiety after ovulation, and also I've experienced the disappointment and heartache when you have a negative pregnancy test. So, and ultimately, you know, the joy of conception, pregnancy, birth, and of being a parent. So I really want to help everyone who want to have this experience to be able to have a family.
Thank you. Ms. Wiesner?
Hi, I'm also really honored to be here. I have a practice in West LA, and I practice traditional Chinese medicine. So I do not only acupuncture, but I also look at people's diets and their lifestyle. And I'm sure no one understands stress who's going through fertility, so we look at a lot of stress. And you know, go into details about food. I have a full herbal pharmacy of herbs in my practice and make custom formulas for patients. I work with patients going through assisted reproductive medicine technologies, and we'll go to IVF centers and do acupuncture before and after IVF. But I really like to work with patients and women and men before, way before, about 3 months at least before they consider doing, if they're going to do an in vitro cycle, just to get their bodies prepared. But I will see a patient at any time. I personally got into doing women's health. I've been in practice for about almost 20 years, seems to be the theme, 20-year thing. And I found out I had a genetic disorder called Tay-Sachs when my child, when I was pregnant with my firstborn, who's now 16 years old. And I didn't know. I thought, oh, I'm never going to have problems getting pregnant. It's no big deal. And then I found out my husband was also a carrier of Tay-Sachs, so I found out I'd have a 25% chance of each pregnancy being okay, of not okay. So my first one luckily was okay, but then I went on to miscarry, my second one, and then I had a Tay-Sachs child I needed to terminate. And in case you're wondering what Tay-Sachs is, it's a genetic disorder where there's a chromosomal, where there's an enzyme missing for development, and so it's fatal. A child will live 1 to 2 years and could die. So I found out I had a Tay-Sachs child, and I had to terminate 3 months after having a miscarriage. And then I had the whole thing of like, well, I should be able to get pregnant because I've gotten pregnant 3 times, no problem. Then I couldn't get pregnant. And I remember, doing tests every month, feeling up myself, sure I was pregnant, and finding, the negative sign over and over again for a year or so. And finally, with some test, I did a thyroid panel and found out I was a low thyroid, and did acupuncture and herbal medicine and all the stuff I believe in, and then conceived my second child. So I have great compassion for women and also for men going through this journey together, and I'm just very honored to work with my patients and whoever enters my practice.
Thank you so much. Just to tell you guys a little bit about myself before we get started, as Justine mentioned, I do have a blog where I talk about my personal experiences, and that is 3 years of infertility, a lot of the similar, ovulation tests and timing and cycles and all of that. Finally did do an in vitro cycle, which was a successful but turned out non-viable pregnancy. I now have a beautiful, healthy, amazing daughter as a result of a frozen embryo transfer, excuse me. And I hope that the information that our panelists can give you guys today can help you on your journey, much like similar people helped me when I was going through similar stages. And a reminder too, if you want to go and find any other information about any of our panelists here or any of the other topics, you can just go to fertilityplanet.com, and there'll be all of that additional information if you want to contact anyone personally and discuss anything with them. So we'll get started with some questions. We'll start with you, Dr. Mars. How do you know when it's the right time to go see an infertility specialist? Like, a lot of people are in that stage where they're trying at home, they're maybe talking to their OB, but when do people know it's time to go and see a reproductive endocrinologist? Like, take that next step.
I just happened to brought some slides with me.
Oh, absolutely. Please share with us.
I didn't know that question was coming up. One of the biggest problems that we still see as a subspecialty practice is that patients don't always come in a timely fashion, come in to see us. They stay with their family practice doctor, they stay with their OBGYN, and just don't get moved along, and time is important. Time is very important when fertility is an issue. Some of the things I just want to briefly share with you are some facts that are very important for you to know, because those facts are how I tell patients kind of what the timing should be. First of all, when you look at what causes a couple to be subfertile or infertile, basically about half of the issues are female issues and half of the issues are male issues, and another 20% are unexplained. We don't really have an answer for them. So the male and female are pretty much equally involved when a couple's not conceiving easily or naturally. When you look just at the female side of the fertility question, about half of the problems with women that are not conceiving properly relates to their ovulatory cycle, their menstrual cycle. Not just whether they ovulate, but how well do they ovulate. Hormonally, do they prepare the uterine environment properly? Do they release the egg properly? Do they support the second half of the cycle properly from a hormonal standpoint? So when I talk about ovulation problems, it's all of those things. Not just does she have an LH test that turns positive and she ovulates or thinks she ovulates. 30% of issues with women can relate to fallopian tube environment, fallopian tube function, the uterine function, the development. Was the uterus developed properly when she was in fetal development? And
Yeah.
I'm not going to move. 10% are unexplained and 10% cervical. One of the most common things that we see when we talk about cervical issues, cervical mucus production and sperm interaction is the only mechanism by which sperm enters the upper reproductive tract at the time of ovulation. A woman who's had an abnormal pap smear, HPV, had a LEEP procedure, had a cryocautery of the cervix, sometimes can have a problem with cervical mucus production. So these things are important to know when you're thinking about getting pregnant and you say, is there anything in my history that I know about that could make me subfertile? That kind of, if there's a yes answer, that kind of takes you a little faster into a subspecialty reproductive endocrine area. What I tell people and try to get them to focus on is these are the four main principles that determine timing. What is the age of the woman at the time she decides to become pregnant? How many months has she tried? What's the regularity of her cycles? And is there a family history? Did her sister have problems? Did her mom have problems? Did his brother have problems? Did he have low sperm count problems? If there's something known in the family, these are the four things that I tell people to focus on, and then I kind of give them this little table. A woman under the age of 35 deciding to get pregnant that has regular menstrual cycles, she really should give herself 4 to 6 months of trying. Go ahead and time ovulation, but try to conceive. You don't need to run into a doctor right off. If your cycles are not regular, if you have sporadic menstrual cycles, you may as well go see your family medicine, OBGYN, try to get regulated in your menstrual cycles, and then try to get pregnant. Somebody over 35 and 35 to 40, shorten the time. If the cycles are regular, try for 4 months at least. See if you can get pregnant. If not, then move on to an OB-GYN that has some experience in regulating your cycles if you're irregular. Or after 4 months, see a reproductive endocrinologist. Over 40, I really think women ought to go to somebody that's well-versed in fertility medicine, has a setup to diagnose them and treat them quickly. Same thing with a family history. Somebody that has a father or a brother that has known sperm problems, he needs to come in. They need to come in sooner. They need to be evaluated. Then they may be able to go ahead and try for a while based on her age. But these are just kind of common sense issues that tell us when patients really need to move along. How do you know where to go? Well, there's all kinds of ways to do that. When you're choosing a doctor that's in the area of fertility treatment, no matter who that doctor is, you want to know what that person's experience and training was. Is this person had the right training, fellowship training, board eligible, board certified, whatever. Reputation in the community is always important. Ask people, ask your doctor, ask your family medicine, ask your OB-GYN. What are the people, who are the people, and what does the medical community think about them? Talk to your friends. They've been there. They've been to somebody, 2 people, 3 people. They can give you their perspective. The bottom line is you will meet who you want to work with. And you'll need to talk to that individual. And you want to know that you've got some level of comfort dealing with that person. What's the game plan going to be? What's the treatment plan going to be? Is this person too aggressive or too not aggressive enough for me? You know, it's a personality thing. There's a lot of information that you can gain from the web, from the internet. There's sources. You've got Resolve. You've got fertility groups. There's various mechanisms. You go to the internet and look and see what the community is like, who the physicians are, what their practice is like. But it is important, I think, to know when you go in. You may come in to see me for a first visit, and we go through everything, and you walk out and say, you know, he's an okay guy, but that Texas drawl just kind of drives me crazy. I'm going to maybe go see somebody else and see if I feel any different. And a lot of patients will do that. And that's important to do because you need to be comfortable. This is a very intense, emotionally draining, physically draining, and financially draining process if you have to go through an extensive fertility workup and treatment. The basic tests are pretty simple. The first thing we want to do if you come in to see one of us or a reproductive endocrine person, you want to establish the ovulatory pattern, make sure it's normal, make sure the factors that I said before and after egg release are normal. You want to know that the sperm analysis, semen analysis, sperm function is normal. Check the uterus fallopian tubes. Hormonal testing, all of these things are just basic, quick tests. You can basically do all of these tests in one menstrual cycle. Your OBGYN a lot of times will do these, but you need to have them done. This is where we determine what the initial game plan is going to be for somebody that has not become pregnant with normal attempts. Thank you.
Thank you. Thank you, Dr. Mars. Dr. Lee, we wanted to ask you, what are the different treatment options that are available? He talked to us about the testing to get us started, but then once that's completed, what comes next?
All right. I think I have some slides too. Okay. No?
He's got to get them up.
Okay. One second. Let me just skip through some of these. Okay. So infertility treatment. Actually, I'll skip the animation. But basically, infertility treatments can be broken down into 3 categories. It's a simplified way of looking at this. So you can, starting with tier 1, which is low tech, and what we call plan A at PFC, is ovulation induction or superovulation with medications such as Clomid or letrozole, oral medications, or injectable hormones, injectable FSH. And the goal is to stimulate the ovaries to ovulate somewhere between 1 to 5 eggs at a time. And during the time of ovulation, concentrated motile sperm can be inserted into the uterus to facilitate fertilization and implantation. This treatment option really is appropriate for young patients who may have ovulation dysfunction. For instance, someone who has polycystic ovary syndrome, where they have a intrinsic endocrine disorder, imbalancing hormones that prevent them from ovulating regularly on their own. It's appropriate for couples where the main reason for infertility is mild to moderate male factor, where the sperm count or motility are reduced. It's also appropriate for couples with unexplained infertility. It may be appropriate for someone who have decreased ovarian reserve, either due to age or other factors, but it doesn't work quite as well in those circumstances. It is not appropriate for patients with severe male factor, where total motile count is less than 5 to 10 million, or it's not appropriate for patients with obviously blocked fallopian tubes, because you do need patent fallopian tubes in order for insemination to be successful. Plan B, middle tier, is really where we start to utilize our technologies in the laboratory. This is in vitro fertilization, IVF. And the goal of IVF is to optimize every step along the way leading to implantation. Starting with superovulation again, using injectable hormones to stimulate the ovaries at this time, instead of just doing 1 to 5 eggs, but stimulate the ovaries to produce as many eggs as possible in one cycle, anywhere between 10 to 20, depending on a particular person's ovarian reserve. And when the eggs are mature, they are harvested from the woman's ovaries via a procedure called transvaginal egg retrieval. And then the eggs are fertilized with either the partner sperm or donor sperm in the laboratory in the petri dish, so hence in vitro fertilization. The resulting embryos are then grown in the laboratory for somewhere between 2 to 6 days, at which point one or more developmentally appropriate embryos are then transferred into the uterus for implantation. Because every step is optimized, it does have increased success rates compared to ovulation induction with insemination. But I'll show you in the next slide. But both of these plans, the chance of success really depends on ultimately the woman's age. One problem that in vitro fertilization cannot solve ultimately is a problem with the egg. despite the fact that we can use high-dose medication or multiple different types of medication and trying to physically in the laboratory fertilize the egg with the sperm, ultimately it's not going to allow us to change the quality of the eggs in our ovaries or get more eggs to grow when there aren't any. So in patients who have severely diminished ovarian reserve, who either because of age or because of other medical endocrine issues, then the only viable treatment plan to conceive would be egg donation, IVF through egg donation, which is Plan C. IVF with egg donation really happens just like a regular IVF cycle, except separated into two parts. The egg donor, who is presumed to have good ovarian reserve, someone typically between the age of 20 to 30, undergoes the ovarian stimulation and egg retrieval, and her eggs, after harvesting, are fertilized with either donor sperm or the partner's sperm, and then the resulting embryos are transferred back into the intended parent, the original patient, the recipient's uterus for implantation. And the success rates of egg donation really depends on the age of the donor. So typically these donors are selected based on good ovarian reserve, and because of their young age, typically the success rates are very, very high. There might be some reduction in success rates in recipients who are in their late 40s or early 50s, but overall the rates are pretty much independent of the woman's age. In terms of, actually I'm just going to go, I made more slides than we have time to talk about. Well, actually, let's talk about in vitro fertilization a little bit more. Again, we recruit multiple eggs with injectable hormones, and then we do a, egg retrieval process. Where's the, there. Can you see? Yeah. So this is an ovary that has been hyperstimulated with injectable hormones. This is a transvaginal ultrasound, and each of these black circles is a developing follicle. Within each follicle is a maturing egg. We cannot see the maturing egg with our naked eye, but we can see it microscopically under the microscope. So a transvaginal egg retrieval is there's a needle that goes through the vaginal wall into these follicles. It's hooked up to suction, and the fluid is aspirated back, and usually the egg comes with the fluid, and the embryologist looks through the fluid under the microscope to collect the eggs. They're then fertilized with a sperm, either by combining the sperm and the eggs together in the laboratory in one dish called conventional insemination, or in patients with severe male factor, you can inject each mature egg with a motile sperm in the process called intracytoplasmic sperm injection, otherwise known as ICSI, to allow fertilization. And the embryos later on are then transferred back into the uterus via an embryo transfer procedure that doesn't require anesthesia. It's very much feels like an insemination or a pap smear. Okay, egg donation, we'll just go through this. So this is success rates, cost, and complications. And it's a little bit of a busy slide. You can take a moment to take a look. But despite the fact, Dr. Mars told us that reasons for infertility is equally divided up between men and women, but ultimately success rates of treatments are based largely on the female's age. So when you look at no treatment, between age 20 and 30, this is infertility patients who've been trying on their own for a while, 10 to 15% per month. And if you are doing Clomid with insemination, you're maybe increasing it by 15 to 20, but that's probably as high as you can get with ovulation induction with intrauterine insemination. Injectable FSH with IUI increases the rates a little bit more. IVF in someone who's 20 and 30 is probably that's the group is most likely to be successful with IVF, and we can achieve rates somewhere between 50 to 70%, similar to egg donor IVF cycles. These are not just our center's data; it's kind of estimation of national data. So as the woman's age increases, you can see that the rates across the board decreases, with the exception of egg donor. And in someone who is in their late 30s or early 50s, doing Clomid with insemination or gonadotropin with insemination really yields very little return. And even IVF, you can still get pregnant with IVF in your late 30s and in your early 40s, but after 43, 44, success rates with in vitro fertilization is very, very low, probably on the order of 1 to 5% per cycle. And after 45, really, the chance of conception using your own eggs, even with IVF, is essentially zero. So at that point, egg donors are is the only viable option. So looking at the complications of these various treatments, when you do ovulation induction and stimulate more than one egg to drop, there's obviously a risk of having twin implantation and potentially even more triplets or more. So with Clomid, typically we don't produce more than 3 or 4 eggs at a time, so the twin rates is there, but triplet rates is pretty low. With injectable hormones with insemination, because there is higher risk of ovulating more than 2 eggs at a time, it does increase the risk of twins, and there is definitely a realistic risk of having triplets. With IVF, it depends on how many embryos we place back into the uterus. That determines ultimately the risk of twins and triplets, and that is age dependent. Again, quality of the embryo determines whether you're going to have 1 implantation or 2 implantation. And typically, triplets are only in those patients that we transfer multiple embryos. And there have been efforts across the nation to try to reduce the risk of triplets and higher order multiples by practicing elective single embryo transfer in patients who have good prognosis. And then the cost is obviously escalating, increasing depending on the technology that we use.
Thank you so much, Dr. Lee. Ms. Wiesner, we have a question for you. We heard from these guys about the artificial reproductive technology, or assisted reproductive technology, I should say, and those technologies. But what can a person do to help themselves when they want to get pregnant? It's not happening, but they want to optimize their fertility naturally, either complementing these types of treatments, which I know a lot of people do, or maybe even as an alternative to some of the more invasive procedures. What are some options available?
So when a person goes to see a Chinese medicine doctor or myself, the first thing I do is I look at the body, mind, and spirit. I want to look at all aspects of a person. So I'll look at someone's sleep. Are you sleeping enough? Some people that I see sleep about 6 hours, or they sleep very little. That's where the body restores its hormones. So you want to make sure you get at least, I hate to say 8 hours, it's individual, but you want to look at your sleep and you want to wake up feeling refreshed and ready to go. And that brings me to coffee. A lot of patients are not feeling refreshed and ready to go, so will often indulge in caffeine, and not 1 cup, but 2 and 3, and then have to have an afternoon chocolate to pick themselves up, which brings me to sugar and refined products and nutrition. So I look at sort of how everything's functioning. How is digestion? How are you assimilating the nutrition that you're taking in? What are you eating? Are you eating, stopping for fast food and feeling like your digestion, you're bloated and maybe constipated? And so I go into great detail, but for both men and women, about the whole functioning of a whole person. And I will look for women specifically on their reproduction, so their menstrual cycle. In Chinese medicine, we look in great detail in the color of the blood. So for example, some women have a lot of clots and a lot of painful periods. I might recommend herbs and or things like fish oils and things that thin out the blood a little bit so there's less pain and there's more flow, and other special herbs. I will look at to see when a woman's ovulating, making sure they're talking about, Dr. Mars is talking about good cervical mucus. I want to make sure a woman's having good cervical mucus, and there are things to do to help cervical mucus. Things I recommend very individually. So I don't usually put 2 people on the same herbal program, but look at the individual and see what that individual needs to maximize their fertility. So things that will maybe thin out the mucus and make more cervical mucus. And I try to maximize egg quality. And things like royal jelly, and there'll be some supplements. I'm throwing things out, so it's not, you should run out and get royal jelly tomorrow. But coenzyme Q10, and we will use special herbs that have been known to help with fertility in a concoction or a powder or boiled herbs to help a woman have a regular cycle so she's not ovulating very late, but ovulating in the mid-cycle, day 12 to 14, and having a very strong second cycle, a luteal phase, that's at least 14 days. So I look at detail into the menstrual cycle. And with males, I'll look at their sperm count and make sure that their motility is good and their morphology is good, and I'll try to maximize that with herbs and diet and exercise. I mean, you know, and other things like putting a laptop on your, you know, family jewels at night. People don't think about that, but oftentimes that happens. So I'm looking at all of those factors and then coming up with a custom prescription. So that's pretty much body, but I also deal with mind and spirit, and I think those are essential when you're having struggles with fertility or if you're just trying to conceive. Oftentimes, men and women, they're trying to conceive, and there's like pressure to make a baby tonight, honey, we have 5 minutes, and it becomes very stressful, and then there's issues in the relationship. So I try to work with both men and women to really bring back this idea of receiving and what it means to really conceive a child. And it doesn't matter whether someone's going through in vitro or insemination. It's this idea of using the acupuncture, herbs, meditation, lifestyle to bring this receiving into a woman, no matter how it's conceived. I think sometimes people do need to have tests done, and I will recommend that they go see a specialist, such as these people, to maximize their fertility, to test their ovaries. But I really, in Chinese medicine, the heart energy up here is connected to the uterus for a woman, and we have to receive this baby. So stress management, making sure that people are relaxed, making sure that people, you know, there's this whole thing of like, how much do I need to do? I have my list. I'm going to check off. I've done acupuncture, I've done massage, I meditate, I eat well, I'm now juicing, and why isn't the baby happening? So I feel that sometimes that what I see in my practice is this idea of, I want to say letting go, not of the dream, not of the wanting it, but letting go of the struggle. I think that there's a lot of struggle in fertility. You're laughing, so I bet some of you feel that. And that there's this idea of trying to find peace and to make the journey as loving and wonderful as it can be, no matter how this baby is conceived, that it doesn't create problems in a relationship. And that's what I do with the acupuncture. It helps balance the reproductive, the hypothalamus, pituitary, ovarian axis. I can help people to ovulate. I can help people that have polycystic ovarian syndrome to balance their blood sugar so that they can have regular ovulation. I can help people with endometriosis and just various things to help create this optimum environment so that a baby can be conceived.
Thank you so much, Denise. So you heard a little bit from all of our panelists, and hopefully they answered some of your basic questions, but if you have more specific things that you might want to know, this is a really great opportunity. We're going to have Justine come around, and if anyone has questions, does anyone have anything they want to ask anyone specifically or just vaguely? I think right here. Right here.
Oh, great.
This question is for Dr. Mars. You mentioned the testing. A lot of the tests have to do with where you are in the cycle. If there's no cycle, how do you do the testing?
Well, that's a big problem to start with. Without a cycle, you're probably not ovulating. So that's one fact that immediately needs to be addressed. And so I'll see a patient that comes in for a first visit, and the first thing we talk about is what her menstrual cycle activity is. It sounds old-fashioned, but it's the piece of history that's really important. Somebody who has very irregular cycles, the first thing you want to do is establish an ovulatory cycle. What I normally do in that situation, we'll do an ultrasound to look at her ovaries to make sure that she's not got some type of cystic activity. But then we'll induce a period based on baseline blood tests. Those 4 blood tests you saw, the hypothalamic pituitary testing, just measures the FSH, LH, estradiol, prolactin, and TSH. And that tells us basically where we are as far as pituitary balance. Those things will say it's okay to get this woman into a menstrual period, and then from that point, use something like clomiphene, for instance, to get her into an ovulatory event. Once you establish the period and the start of ovulation, then you can start doing those other tests, because the hysterosalpingogram is done after a menstrual period is completed. The ovulatory testing, the way I follow somebody through an ovulatory cycle, is look at them. If they're having periods, we'll look at them with an ultrasound on day 2 or day 3 with the baseline blood test. And then if they're having periods, we'll have them do a home LH test. When that's positive, I have them come in the next day for an ultrasound. And what I'm looking at that time, I'll look at her cervical mucus production. I'll do an ultrasound to look at her endometrial development and look at her follicle development pre-ovulatory. And that's how we assess whether she's prepared herself properly for that egg release that's happening that day or the next day. And then about a week after that, we'll measure her estradiol-progesterone ratio for the luteal implantation support. And that tells you basically what you need to know about somebody's ovulation. But if somebody's not ovulating, you need to get them into an ovulation and then do those tests. The HSG can be done after any menstrual period is completed early in the cycle.
Thank you so much. Does anyone else have any? Okay.
Yes. Hi. I wanted to know, what advice would you give for choosing a doctor if you're just starting this process, IVF, and considering egg freezing? What questions would you ask of doctors in terms of success rates? Any advice you have about choosing a doctor would be helpful.
Dr. Lee, would you like to?
Sure. I think Dr. Mars had a great slide on this, but in terms of choosing the doctor, experience and reputation really is very important. And how do you gauge someone's reputation, someone's experience, because you've never met that physician or that practice, and you just go to sources that you trust, which for most people are their own doctors or their friends who've gone through this. And you can, the internet is a wonderful place, and you can glean a lot of information from the internet searches. And ultimately, I think the physician-patient relationship is such a sacred relationship, and success really comes from mutual trust. So ultimately, you have to meet that physician, that practice, and feel. And this is kind of where it's touchy-feely, and there's no way to really tell, and everyone probably knows it within themselves, whether that person is a fit for you. But the homework starts with looking at that their clinic. Some of the hard facts are on the national database. You can get information about a particular clinic's success rates on the SART data website. Doesn't tell us everything about that particular clinic, but it gives an overall picture. And just research into the physicians and how long they've been practiced. Are they legitimate, board-certified physicians? Do they come from good training programs, et cetera?
I would just add one other thing. You asked about oocyte freezing. That's probably one of the newest areas in the technology field that we're dealing with. And that's very specific. And it's a technology that has been considered purely experimental, and in fact, our egg freezing program is still under institutional review board. That means it's an experimental process, and we have oversight and reviews. 2 months ago, the American Society for Reproductive Medicine placed a statement out saying that oocyte freezing was, by our organization, ASRM, they feel like it's not truly an experimental process anymore. There's enough clinical data that allows it to be used on a clinical basis. But something like that that's that specific, you really want to probably spend a little more time looking at a particular center and how much experience they've had with egg freezing, who does their freezing. The IVF cycle to stimulate eggs is pretty standard for somebody who's freezing eggs, but that embryologist who's freezing those eggs is the critical part of that. And you want somebody in a center that has a good experience with a good embryologist, that's a good cryobiologist for something like that. So you can look at 100 IVF centers and see a lot of similarities, but when you're looking for something that's very specific, like oocyte freezing, you want to ask some basic questions. How long have you been doing it? What kind of results do you see? Have you thawed many of these eggs? The big problem with egg freezing today is that we're freezing a lot of eggs, but the purpose of freezing is for those women to maintain their fertility 5-10 years from now. So there's not a lot of data that's accumulated with the thawing of these oocytes and knowing what their function is. What we do have says that pretty much the outcome with frozen eggs is very similar or the same as what you see with fresh eggs of that age. So if you thaw 34-year-old eggs, when you thaw them out, they should function like fresh eggs at age 34. If you freeze a 40-year-old egg, it's going to function as a 40-year-old egg when you thaw it out. But nobody in the United States or around the world really has, there's not 1,000 cycles of thawed eggs that we could look at birth rates with yet.
Thank you. I have one right here.
As far as the blocked tubes, because I just did an HSG, and it's looking like there's a blockage there, maybe a complete blockage. They haven't told me for sure yet. So the first question is, what are the options there? I guess maybe there's surgical options, maybe not, depending on how blocked you are. And then also as far as the retrieval of the eggs when you're blocked. And then a totally different question, if we have time to ask too, is as far as financial goes, are there options out there for low-income families or potential families? Is it all out of pocket, or is there insurance or something like that that can help?
Well, I'll address the first part of the questions, which is about the blocked fallopian tubes. If both of the fallopian tubes are blocked, oh, I'm sorry. So if both of the fallopian tubes are blocked, then really the only treatment option, the viable treatment option, is doing IVF, in vitro fertilization. Surgical intervention in terms of having surgery and trying to remove scar tissue or reopen the tubes have been attempted, but overall success rates are not very good because typically the underlying reasons are not being addressed. Whatever reason that caused the tubes to be blocked in the first place are still going to be there after surgery, which can render the fallopian tubes dysfunctional, even if they are open. And also surgery increases the chance of scarring anyway, so that the tubes can close back up after the surgery. There's a subset of fallopian tube disorder where they're not just blocked, but they can potentially be dilated and filled with fluid. These are called hydrosalpinx. And if that were the case, then there's some evidence that these fluid accumulated in the fallopian tubes can decrease the success rates of fertility treatments, in which case, even though the treatment still is going to be IVF, you may consider taking the fallopian tubes out prior to doing IVF treatment just to improve the chance of success. And then other thing about fallopian tube blockage is that, let's say if you have partial blockage or one side is blocked, you may still consider doing insemination. You are at an increased risk for potentially developing a tubal pregnancy. Not to say that that will be the majority of the pregnancies that conceive, but I think patients should be aware of the fact that there is a slight increased risk of a tubal pregnancy, which can complicate issues later on. And then
you also were asking about
aspect.
financial aspects. Is that right? Does anyone have any insight on that? Dr. Mars?
Yeah, that's probably the thing that I've struggled most with in 3 decades of doing this is trying to provide affordable care. And as everything else in the last 30 years, medicine costs and medical care costs have escalated out of control. just going back to a particular situation, and this is a gender gap now. You're going to hear the old guy talking about tubal problems, because when I left Texas, I thought I could operate and fix anything that was fixable from a surgical standpoint, and quickly found out that that's not true when you get a little older. But there still is a role for surgery, especially when there's maybe a block on one tube and the other tube's normal. And the reason I say that is that sometimes a collection of fluid in the fallopian tube can be from a very minor narrowing of the end of the tube or scarring around the end of the tube from something like endometriosis. And so in that situation, even though IVF has always been kind of thrown out there and saying, well, let's just do IVF, I still will certainly evaluate a pelvic environment by laparoscopy in particular situations. And a lot of times, because of some discomfort and menstrual pain and things, with pelvic pain as part of the diagnosis, an insurance company will allow a diagnostic laparoscopy, which may be a therapeutic laparoscopy. If you go in and find some narrowing, you open it up with a laser, and that tube actually is a very functional tube. And the opposite tube has a little adhesions you remove. And then you can come back and try to conceive with minimal type of assistance. When you have bilateral tubal blockage and expanded tubes, I agree. Today, IVF is a better alternative. There are some programs that can get IVF costs down. Some of them relate to centers that do clinical trials. Clinical trials are things when we're looking at medication improvements or various things. A lot of the centers will have clinical trials where patients that qualify based on age and that sort of thing can come in and actually, get almost an IVF cycle that may be very little cost to them. Some programs will run, for instance, in our program, teachers, firemen, policemen, I do everything I can for them. They come in, we do it, we get drugs for them, whatever. So you need to talk to who you're seeing and see what options they offer because of the cost and try to work something out. And, if you have to do an IVF cycle and it takes 2 years to pay for it, so what? You pay it out over time. So there's ways that you can. There's really not any good insurance plans. The plans that are out there for IVF insurance actually are more costly, I think, than what it costs to pay for a cycle. There are some plans out there, but I haven't been real satisfied with them. I tell people to work with your doctor, work with the group, and see what can happen that way.
And just grants exist as well. If you guys ever have a chance to get online and do some research on that, Resolve is a good resource. Fertility Planit might even have some resources available for you to get some more information on those kinds of programs. I think we have a little bit more time for...
So with all of the tests and the procedures, it can seem so overwhelming and it can seem endless. So is there a time to stop? Is there a certain age? Is there a certain number of procedures or a certain number of tests? Like at what point is it time to stop, or is it truly endless? Can it go on and on?
Well, there's definitely an end point. And the older I've gotten, the clearer that end point is in a lot of patients. When I was starting out, I was not willing to give up on anybody, anytime, anywhere, any place. And you find that that's not the best thing for the patient. When I talk to patients at the initial evaluation, I give them what we're going to start with and how long and what the end point's going to be. Because if they don't achieve a pregnancy with the detailed plan or the game plan that we start out with, they know up front that there is a limit. There is a point that there's no sense going there. Even if they want to go beyond it, the medical, technical, scientific process just won't support beyond that point. Now, that's always a hard thing, and I've had a lot of times where I've set that and talked to couples about stopping, and they say, let's go one more time, and I'll be damned if they don't get pregnant that time. So, and it does, it happens. And even though I don't feel good about going beyond that, they've asked to, and we've done it, and you'll occasionally get a pregnancy. It's important, I think, that's all discussed at the beginning, so you have a game plan. I think the stress in dealing with all of that, Denise was not, I've got a say more about what Denise does because I think it's extremely important. What she and her colleagues do for us in these cycles is just unbelievable. How they get the patient to be more comfortable and less stressed by the stuff that they're going through is important. Probably 70% of patients that I work with are working with someone like Denise or Denise. And I think it's extremely helpful. It's helpful from a medical standpoint. It's helpful from a physiologic standpoint. It's helpful from a psychologic and stress standpoint. And I think that allows patients to get to the end of that if it happens, and they're ready, more able to accept the fact that we just don't have anything else to do if they've gone through that process with that type of balance.
And with that, Denise, do you have anything to add?
I wanted to say sometimes you see, and I see this quite often, and you hear this, but you see people who completely give up. I had a woman who had a miscarriage at 45, or 44, and she came to me around 45, and if you look at those statistics, it's very, very low pregnancy. And we did a lot of stuff for her. She was in my support group, and she kind of gave up, and at almost 47, she conceived. So barring that there's no, big issues, I don't want to say that's going to happen to everyone who tries, but sometimes you get the patients who actually let it go and decide, I'm not going to try more IVFs or whatever, and then sometimes things happen, and sometimes they don't, and they do other things, but if that's viable for them. Sometimes it's just there's blocked tubes and IVF is the only solution, but I see a lot of amazing things happen all the time, and I can't stress that letting go and stress reduction is a key thing for fertility.
Well, thank you so much, everyone. I really appreciate all of you being here. I appreciate our panelists, Dr. Mars, Dr. Lee, and Denise Weisner. Thank you to our audience, our live audience here in the room and online, watching on UStream. Please continue to share your experiences this weekend at the event. You can be on Facebook, on Twitter. The hashtag is FPS13. You can also view all of the programs from the weekend starting on Monday at fertilityplanet.com for free this weekend, and then starting on Monday, there'll be a podcast. I want to thank UStream for recording all of those programs and making them available to everyone. And very big thank you to Fertility Authority. They were our sponsor for this wonderful event, for this panel. Before we go, I just want to give our panelists one last chance. Is there any last thing that you want to any information you want to give to anyone? Any last words of wisdom or encouragement, maybe? Okay.
No, just don't give up on the dream of having a family, but there are alternative ways to have a family, so it doesn't always have to be one. Just like what Denise says, just let go, and sometimes things will happen, but we're here to support you.
Okay, and Ms. Weisner's clinic is actually featured at the exhibit hall this weekend, so you can find her if you have more questions, if you want to get more information about what she does. I'm not sure if your clinic's here as well, so yeah, you can absolutely come and find these guys, talk to them, ask any questions you might have on a more personal level or things that didn't get addressed here today. Thank you all again so much for being here.
When we talk about embryogenetics, you actually take a single cell from the embryo during its developmental stage, and you can analyze it for any genetic abnormality. Before the embryo reaches a stage, it's transferred back to the uterus and the pregnancy starts. The most common reason to do it is if there's a family history, like Denise mentioned, Tay-Sachs carrier. You can actually